So we can start.
All right, okay, great. So any questions so far? Wells criteria, or we can go on to clinical features. So as I said, it's yes, please.
Yes, sir. Can you possibly go over the Wells criteria? We didn't get that.
All right, okay. So basically, it's a criteria we use in clinical practice to assess the probability of deep venous thrombosis. So it's not like it tells us that this is a deep vein thrombosis or this is not a deep vein thrombosis. What it tells us is that this is likely to be a deep vein thrombosis. So attempt or deal with it, with all the expertise that you've got, because this is likely to be a deep vein thrombosis. It can become an emergency any moment from now. Or this is not likely to be a deep vein thrombosis. So consider other options, okay? But it's not as if it will tell you that this is DVT or not. It's not a gold standard for telling us that you have a DVT or not, okay? So that is what the Wells criteria does for you. So when you look at it, it has parameters. So for instance, if you have a patient coming to you with a swelling of the calf area more than 3 centimeters, you compare it to the other leg, which is not swollen, you realize that the calf is more than 3 centimeters swollen than the other leg. When you press, there's some form of pitting edema, okay? And then you also check, you realize that at that particular leg, at that point where it's swollen, you can also see some form of veins or visible vein over there. When you touch, it's very tender. Okay, you realize that these are like criteria that is basically, coming with active points, which we have in our Wells criteria. So the swelling of the leg alone will be +1. If you have a pitting edema, it will be +1. When you realize that, all right, when you touch, it was very tender, that is +1, okay? So once you have all this is like +3, and +3 is more than 2. So then you say the patient has a positive Wells score. It means that this swollen or painful swollen leg is likely to be a DVT. But then if you check and you realize that there's no pitting edema, there's no pain, the leg is just swollen, then you are getting a Wells score of just 1, which is less than the 2. So you go like, oh, this is not likely to be a DVT. An example is you have a patient who has a lymph edema, okay? Lymph edema would usually come with a swollen leg because you have the lymphatic tissue in that leg is basically what's compromised. So it's unable to distributes the lymph in the leg upwards, okay? So it's like you have an incompetent lymphatic tissue in the leg. So with lymphedema, the leg will still be swollen, but then the patient will have no pain, okay? Usually they don't have pain, usually. And then when you touch, you realize that the edema you get from lymphedema is non-pitting. So there and there you can see, what the patient has is only a swollen leg, which is not painful and it's not pitting. So this patient will have a score of just 1. And a score of just 1 is, of course, it's less than 2. So then you say the patient has a negative Wells score, meaning that it's not likely that this swelling is a DVT. Are we okay? Can I go on, please?
Yes, Doc, please, let's go on.
All
Yes,
right,
sir.
okay.
So
It's a little confusing for me.
Where's the confusion coming from, please?
It's the confusion, especially when we get down to where you were talking about swollen unilateral superficial vein. You talked about the negative score. I don't know when the negative score comes in. That is what is a bit confusing for me when
Oh,
we talk about the
okay.
negative score.
A negative wall score means that the values that you are getting you are not getting a value of 2 or more. Then we say you have a negative score. So that's why I gave an example that you have a patient who has come to you, you are seeing the OPD, and the patient has a swollen leg. And as I always say as clinicians, when you see a swollen leg, one side, unilateral leg swelling, what you should be thinking about is DVT, okay, so that you don't miss it. So as soon as unilateral be what a DVT, because if you have a unilateral leg swelling and it's a cellulitis, it won't kill the patient fast like the way a deep venous thrombosis will kill the patient. Okay, so as soon as you see, your mind is this could be a DVT, so you are quickly going to examine to make sure it's not a DVT. So when you check and you realize that the only thing to worry about is the swelling, because the swelling is painless, and at the same time, when you touch, it's non-tender. Okay, so you check this and then you can go like, well, it's just the swelling. And as part of our WALS criteria, swelling of the entire leg or calf swelling is just 1. So just 1 means that this patient has a negative WALS score because the patient hasn't made a score of 2 or more. Are we okay?
Yes, sir. We are okay.
Yes, so usually the WALS criteria, as I said, is not a gold standard. It's just a criteria to give you an impression of what you are dealing with. But as a clinician, your investigations are very key because you can say, oh, this is positive WALS score, but you go and do your investigation and you come back and they'll tell you there's no clots. At the same time, you say, oh, this is a negative WALS score, but you go and do your investigation and you will come back and there's a clot sitting there. So it is just there to guide us, but it's not there to help you make a definite diagnosis. Okay. So the clinical features, the symptoms, your patient would usually come to you with swelling of maybe the entire leg or the calf area. They'll tell you that it's swollen and then they have pain. Okay. Sometimes if the clots form there, you've had the clots move into circulation, then they also come with some clinical symptoms of pulmonary embolism. Okay, that is they'll come in with some form of breathlessness apart from the pain and then the swelling of that compromised leg. They'll come in with some form of breathlessness, difficulty in breathing, coughing. All these are symptoms of pulmonary embolism, which we'll be discussing in our next session. Okay. So the symptoms, patients will come in with a painful swelling, unilateral, how do you call it? A unilateral leg swelling, basically. So a painful unilateral leg swelling, that's what they will come in with. And then they can sometimes have some symptoms of breathlessness, depending on the position of the thrombus, whether the thrombus has now become an embolus and it's gone into the patient's lung, they would have breathlessness and all that. Then the signs, you will look and then you realize that the place actually looks edematous when you touch the tenderness. Sometimes you touch and you realize that it is warmer than the other aspect, what we call differential warmth. Okay. Sometimes clearly you can see that there's a vein there, which is what engorged. You can sometimes see it clearly. Okay, so those are the clinical features. You are going to look at the area for edema. You are going to touch for tenderness. You touch and compare the temperatures of both limbs, and then sometimes you see a visible engorged vein. Even though it's condition of the deep vein, what you are seeing there is a superficial vein, because if the deep vein becomes blocked, then you are going to have like the superficial veins also becoming engorged, and sometimes you can actually see it in the calf area. There's a test called Hoffman sign, but we usually don't do it anymore because we realize that sometimes when you ask the patient to do it, the clot can actually break and move into circulation. So it's not a good test to do. Okay. Sometimes when you're hard pressed, you don't have a Doppler in the area and all that, maybe you can take the risk and you ask the patient to dorsiflex. Dorsiflex means that the patient is what? When you take the foot, okay, the under of the foot is the plantar region. The upper aspect of the foot is the dorsal region. So if you ask a patient to plantar flex, it means you want the patient to sort of break the foot so that the toe will point downwards. If you ask the patient to dorsiflex, then you want the patient to move the foot so that what the toe will point what upwards. So for the Homans test, you ask the patient to what do a dorsiflexion or to break the foot so that the toes will point upwards. And usually when it's DVT, once they dorsiflex, they tend to have severe calf pain. Okay. So differential diagnosis is key, and you should know a lot of differentials for unilateral leg swellings because you'll be seeing a lot. As I said, not all unilateral leg swelling is DVT, but always have DVT at the back of your mind because that is what will kill your patient faster. You can have a patient who has cellulitis, which means that you have an inflammation of the subcutaneous tissues. Okay, that is what we call cellulitis. That is also a differential for unilateral leg swelling. Sometimes the Achilles tendon can become inflamed, or we call Achilles tendinitis. That is also a differential. Then there's something called Baker's cyst. Okay, you can have a Baker's cyst or a collection of fluid forming in the knee region, and when this cyst ruptures, it gives you severe swelling in the calf area. You see, when you take the knee, you look at the back of the knee, what we call the popliteal region, you can have a cyst forming there. And when this cyst ruptures, the fluid leaks, you can have a swelling close to the calf and it looks like DVT. You might get confused. If you don't do your Doppler, you think this is DVT because it has almost all the signs and symptoms of DVT. A unilateral leg swelling, when you touch, is warm. It's very, very painful. When you touch, it's tender. But then when you do your Doppler, it will tell you there's no blockage. The blood flow is fine. There's just a cyst which has ruptured. Okay, so ruptured Baker's cyst. We should always keep that in mind. And sometimes the footballers tend to get calf hematoma. Someone can just kick your calf region. You can have a hematoma there. And they can bring that to you in the consulting room. When you see that, even though you are thinking DVT, when you take your history and they tell you someone kicked my calf area, you are thinking this is likely to be a hematoma. And then a fracture, because fracture will also cause swelling and pain. Sometimes you have a peripheral vascular disease, what the diabetics tend to get. So that one in itself causes a poor blood flow to the distal regions, and then you can have some sort of swelling and sometimes some sort of ulcer, which can be a little bit confusing. And then lymphedema, which will cause swelling, but usually this swelling will be non-pitting. Okay. So differentials are very key because you can go into an exam and they'll say all the following are differentials of unilateral leg swelling, except then you have cellulitis, DVT, calf hematoma, then they'll put protein energy malnutrition, or maybe they'll put some congestive cardiac failure there just to confuse you. Those ones will give you bilateral pedal edema, but unilateral pedal edema, that's what we talked about yesterday. I gave you some differentials for bilateral pedal edema. Investigations are very key. Okay, so the gold standard is what we call a Doppler. You do a Doppler ultrasound scan. There's an ultrasound scan to assess blood flow. So if you have a blood clot there in circulation, the blood flow won't be moving as it's supposed to move. The ultrasound scan will pick up an obstruction, sort of, and then it will tell us that there's an obstruction to blood flow, blah, blah, blah. And then we know that most likely there's a clot there. So when you are suspecting that a patient has got DVT, you always have to request for a Doppler. There's also another investigation we do, which is called a D-dimer. Okay, so usually when you do your D-dimer, there's a value that we look out for. If D-dimer is quite high, then we say that most likely you got a DVT. Thing is that high D-dimer is not specific for only DVT. There are other conditions like infections and sometimes some clotting disorders that would also give you a high D-dimer. But if your D-dimer is high in a patient who has unilateral leg swelling and then your Wells score is 2 or more, you're thinking this is likely to be a DVT. So you need to let your patient do an ultrasound scan. Okay. Then sometimes there's a venography that can be done, that you pass a dye into the veins and then you take images of it. If there's an obstruction because of the presence of a clot, the pictures you take would show that, oh, there's indeed an obstruction over there. And then clearly you can make a diagnosis. Of course, it's always good to check your full blood count, because if your WBCs are high and there's the Doppler ultrasound scan is fine, you have a unilateral leg swelling, then you're thinking this could be an infection. Most likely the patient has a cellulitis. Your clotting profile too is very, very essential. Okay. So the complications of DVT, the main complication, what we are worried about is a pulmonary embolism. What is a pulmonary embolism? Here, as the name suggests, an embolus will develop, meaning the clot is going to break and enter into circulation. Once the clot breaks and enters into circulation, because the clot is coming from the venous side, and when you remember the heart failure we did yesterday, it will go through the inferior vena cava, superior vena cava, and end up on the right side of the heart. Okay, once it ends up on the right side of the heart will pump the blood into circulation, pulmonary circulation, to go for oxygen. So in so doing, when the clot also ends up on the right, it's going to be pumped into pulmonary circulation, and then the clot will go and get stuck in the pulmonary circulation, and basically the patient will become breathless. Okay. Are we okay with that? So the main thing we worry about when you are dealing with DVT is PE, and hopefully we will be discussing that within the week. A PE, a pulmonary embolism, clots would break from the deep veins, whether deep veins of the calf, deep veins of the thigh or the femoral veins, deep veins of the abdomen. Clots can just break, enter into circulation, go through the inferior vena cava, get to the right side of the heart. Once it gets to the right side of the heart, your heart will pump it into the pulmonary artery, because that's what it does, to go for oxygen. But this time around, because there's a clot there, it goes and it gets stuck in the pulmonary circulation, and the patient becomes very, very breathless. Okay, so that's why we are always worried about a DVT, because of the complication of PE. Sometimes, however, you expect that, as I've explained, because the clot will end up on the right, it goes into the pulmonary circulation. Sometimes this clot would find its way to the left. How? If there's a defect, okay, in the structure that is separating the right heart of the lung, the right side of the heart from the left side of the heart, you have a defect in there. Then once the clot gets to the right, it can move through the defect and go to the left side. So people who have septal defects, okay, who have a septal defect would have a clot that has moved all the way from the veins to the right side of the heart, moving. Once the clot gets to the left side of the heart, what the left side of the heart does is to pump blood into systemic circulation. So it supplies the brain and all that. So once it pushes, this clot can end up moving all the way, going through the aorta, moving all the way and getting into your brain. And you can develop a stroke from a DVT. And that is what we call a paradoxic emboli. So ideally, the emboli is supposed to end up in the lung to cause a pulmonary embolism. but then it can find its way to the left side of the heart and then get all the way up to the brain or systemic circulation, and we term that a paradoxic emboli. Another complication is people who have DVTs are prone to getting recurrent DVTs. Okay, so once we manage you for DVT, we are looking out for another episode of DVT because they are prone to getting recurrent DVTs. And sometimes when they get a DVT, there's something we call a post-thrombotic syndrome. So after the DVT and all, we realize that sometimes their calf area becomes black, it becomes itchy, and all that is because of the fact that they've had a clot forming in the deep veins before. So, I mean, the veins are compromised in a certain way. So it becomes a little bit itchy. Sometimes it becomes painful and all, but you check, there's no clot at all. That is called a post-thrombotic syndrome. Once you see, you think, oh, there's a clot, let me do a Doppler. You do a Doppler, there's no clot. Okay, so that one is called a post-thrombotic syndrome. Okay, so now we are finishing up. How would you manage a patient who comes to you with DVT? So your main focus there is to prevent a pulmonary embolism from forming. That's your main focus because that is what will kill the patient. So you put all measures in place to prevent a pulmonary embolism from forming. So usually what we do is we anticoagulate our patients. Once the clot has been formed, we put our patient on anticoagulation to prevent the clot from moving all the way up. So we try to anticoagulate our patient. Okay, then the anticoagulation of the patient, the duration of this anticoagulation will be dependent on the cause of your DVT. If you have a patient who has a congenital condition or from birth has a defect in clotting, so tends to clot more than usual, or has less number of anti-clotting factors, so tend to clot more than usual, you don't just say you are putting your patient on anticoagulation for 3 months. This patient will be on lifelong anticoagulation, because as soon as you stop, the patient is going to form a clot. Okay, so basically your duration will be dependent on the cause. But for the standard causes where maybe patient was bedridden and all that, usually you treat for about 3 to 6 months and you keep monitoring your patient. In terms of anticoagulation, what we do is we usually start with our heparins, okay? So the heparins have the ability to inhibit clotting factor 10. And when you should go back to your hematology or your physiology, blood clots, you realize that clotting factor 10 is like the central point. It's just there. Both intrinsic and extrinsic pathway goes through clotting factor 10. So it's very, very essential. So when you block activity of clotting factor 10, it means you've basically blocked blood from clotting in both ways. So then the blood doesn't clot anymore. Okay, so that is what the heparin does. There are two main types of heparin. You have what we call unfractionated heparin. That's what we used to use that in the old time. It's unrefined. And then now we have low molecular weight heparin. Low molecular weight heparin. We are trying to do away with unfractionated heparin, so nobody is actually prescribing it now because it comes with a side effect of excessive bleeding. When you give unfractionated heparin, you have to monitor your patient every now and then to make sure your patient is not bleeding too much, okay? But then the low molecular weight heparin tends to be safer. So I'm sure we've all heard of Clexane or Fragmin. Clexane is a brand name for enoxaparin, okay? Fragmin is a brand name for dalteparin, and the doses are there. Usually when the patient forms the clot for Clexane, we give 1.5 milligram per kg. You can always refer when you forget, okay? So let's say classic, if maybe your patient is 80 kg, and then you make a diagnosis of DVT, you are going to put your patient on 80 times 1.5 of the Clexane. Okay. And then without heparin, you do 200 units. That one, the calculation is in units, so 200 units per kg. You don't have to go beyond 18,000. Okay. So you can always refer when you have a case, but it's easy to remember when you are dealing with Clexane, because Clexane usually comes as 40 milligrams, 80 milligrams. So you can keep giving 120 and all that. So if your patient, you make a diagnosis of DVT and your patient is 80 kg, you know that the amount of Clexane you are giving should be more than what, 80 kg. So if, let's say, you multiply your 80 kg of Clexane by 1.5, what are you getting? You are getting, let me see, you are getting about 120 kg. So then it means you are going to give this patient 120 milligrams of Clexane, okay? Because the patient is 80 kg, you've made a diagnosis of DVT. So we say multiply by 1.5. When you multiply by 1.5, what you are getting is 120. So you can just inject the patient with the 340 kgs or maybe 180 mg and then 140 mg to get your 120. So Clexane is usually easy to remember. But if fragment is what you have, then know you are giving 200 units per kg and don't go beyond 18,000. Okay. So what we do is this heparin, whether low molecular weight or unfractionated, it's not oral. It's an injection. Usually maybe when you are dealing with a low molecular weight, you are giving subcut. When you are giving unfractionated, there's subcut and there's IV. Okay. So you can't discharge your patient to be injecting himself or herself every day. So you have to discharge your patient on what, orals. What we do is that we put our patient on warfarin. Okay. The thing is, warfarin, when you start, it takes about 3 to 5 days to start working. So as soon as you diagnose and you start your warfarin, and you don't stop your Clexane until you've gone beyond your what, 3 to 5 days. Because if you stop your Clexane, basically you've done cost 90, because the warfarin will still be in the system and it wouldn't have, kicked on. But when you start your Clexane, warfarin, and then you want to stop your Clexane after 5 days, by then the warfarin will be working. So you can just stop the Clexane and then you control the clot formation with warfarin. So usually you start with a dose, sometimes you do about 5 to 10 milligrams of warfarin, and then you do a laboratory investigation called INR, okay? Ideally, the INR is what we call international normalized ratio. When you make a diagnosis of DVT, we expect you to have an INR between 2 to 3. The INR comes as figures. When you request for INR, it will tell you 1.5, 3, all that. Just know this, the lower your INR, the more you are at risk of blood clotting. And the higher your INR, the more you are at risk of excessive bleeding. Okay, I'll take it again. When your INR is low, then it means your blood is still clotting. When your INR is high, it means you're at risk of bleeding. Mind you, this heparin, which is coming in to block clotting factor 10, what does it mean? It means a side effect can be bleeding. Okay, side effect of that can be bleeding. So once you are coming in there to give, you always have to monitor your INR to make sure you are not giving too much. Because if you give too much, your patient will coagulate all right, but then you have over anticoagulation. You realize your patient is bleeding from the nose, the ears, your patient can even get a stroke. So you always monitor with your INR. So when you check your INR and you have anything less than 2, you increase the dose of your warfarin. When you check your INR and you have anything more than 3, you reduce the dose of your warfarin. So you see how you do it. So the INR should guide you in dosing the patient. So maybe you started with 10. Now your INR is more than 3. Quickly, you decrease it to 5, and then you repeat your INR. You started with 5, your INR is less than 2, you double to 10. Okay, so that is how we do it. So the last slide for tonight, there's also another oral medication which works like heparin, okay? But this time it's oral. It also inhibits factor 10. It's called it's supposed to be Xarelto or rivaroxaban. So this XARE, Xarelto, this Xarelto would inhibit the activities of factor 10, and it will prevent the blood from clotting. Okay, so it also comes as doses. Your STG would help you with that. Then I also wrote that, so when you have a patient on admission and you don't want the patient to clot, you have to give prophylaxis against DVT. So the other doses we talked about were therapeutic doses. So when you are managing and then the clot has already formed, then you give those doses to treat the clot. But then if the clot hasn't formed yet, what you do is you prevent it from forming. So with Clexane, you can give about 40 to 80 milligrams. It depends on the person's weight. If the patient is very heavy, patient hasn't formed the clot yet, you can give 80. If the patient is not so heavy, hasn't formed the clot yet, you can give 40. If the patient has formed the clot, then you're going to give what? 1.5 milligram per kg, okay? And then the other one, which is the fragment, you are giving 5,000 international units as prophylaxis. The other prophylaxis you can do is, we see it a lot, you let your patients wear stockings whilst on admission, okay? So that's it for DVT. And we can go through the slides. When we meet on Wednesday and you have extra questions, you can ask. But for now, before we go, if you have any questions, you can bring it up and then we answer before the thing drops. Any questions, please?
Any questions? Madam, okay, please unmute yourself.
Hello.
Yes, you
Doc.
can just unmute yourself and ask. Yes, please.
Okay, I wanted to find out the TED stockings, how best does it help?
Well, so you remember what we said about the fact that the veins, they don't have that kind of thick muscular layer, and you need to put on some pressure. So you need the pump action of the gastrocnemius soleus to help it work. When you put on the TED stockings, that is what it does. It offers you that kind of pressure you need. If you get your measurements right, it really helps. If you get your measurements right, because once you are in bed, it keeps compressing on the gastrocnemius area and it helps the blood to move up. If you don't get your measurements right and you just wear it and it's bigger, it's not really pressing on the gastrocnemius area, then you are not getting the effect or the reason why we are even putting you on the TED stockings. But once the measurements are good, yes, it helps. But should I also add that we have patients we put on just TED stockings without anticoagulation and they develop clots. So you don't do the TED stockings alone. If you have access to anticoagulation, yes, you combine the two. But if you find yourself in an area where there's no anticoagulation, you have to put your patient on TED stockings.
Okay, thank you.
You're welcome, Manchester. So God willing, on Wednesday.
Sir, please, I have a question on the
Yes, please.
warfarin.
Yes. Yes, please.
Sir, please, is it advisable to put your patient on warfarin for a very long time? Or it will depend on the INR that will determine whether the person should stop taking the warfarin or not?
Well, so the duration you put your patient on an oral anticoagulation will be dependent on your patient's medical condition, what is causing the clot in the first place. That's why I said that if you have a medical condition which won't go away, you have a clotting defect, so you keep clotting, you would have to be on lifelong anticoagulation. So there's no fixed duration for people who have, those kind of conditions that say, oh, take it for this time and stop. Because when you stop, you end up forming a clot. But for the usual patients who don't have any of that, they don't have like congenital conditions and all that, and probably they developed the clots because maybe they had a fracture, and because they stayed in bed for so long, they formed a clot. For them, usually 3 to 6 months is fine. But of course, you need to be monitoring with your INR.
Okay, so thank you very much.
You're welcome. You're welcome. So hopefully on Wednesday we would complete it with PE. So you can just read around. We'll use about 5 minutes to answer questions on that, and then we'll do PE, and then within the week, when we meet, we'll discuss something else. Okay.
Okay, sir. All right.
I'll see you on
Thank you,
Wednesday,
too.
God willing.
Thank you
All
very
right.
much.
Okay. You're welcome. Bye.
Thank you very much, Doc.
All right. Okay. Bye.
Bye.